Welcome back to USMLE with Varun. This part 2 of our psychiatry series for USMLE Step 1. In this video, we will focus on psychosis, schizophrenia, spectrum disorders, delirium, and antipsychotic medications. These topics are extremely high yield and are frequently tested. Before I begin with the topic, I request all of you to please subscribe and support me. This is an open access platform. This lecture series is provided free and open for all students. There are no paywalls or mandatory fees. If you find it useful and wish to support its continued development, voluntary contributions are welcome. All content will remain free to access. The link is in description and is pinned in the comments. You can pay with UPI, cards, net banking, wallets, and PayPal. What you will learn in this video. Today, we will understand what psychosis really means, different types of hallucinations and delusions, schizophrenia and related disorders, how to differentiate delirium from dementia and psychosis, antipsychotic drugs and their side effects, including extrapyramidal symptoms, neuroleptic malignant syndrome, and emergencies. And we will solve multiple USMLE style pattern questions in this video. What is psychosis? Psychosis means loss of contact with reality. The patient cannot correctly distinguish what is real or what is not. The core features are hallucinations, delusions, disorganized thinking, and abnormal behavior. Hallucinations, delusions, and disordered thoughts. Hallucinations. A hallucination is a perception without any external stimulus. Auditory hallucinations are most common in psychiatric illnesses like schizophrenia. Visual hallucinations usually point towards organic causes such as delirium, drugs, or brain lesions. This is a very common USMLE clue. Auditory for schizophrenia, visual hallucinations for delirium, drugs, and brain lesions. Others include tactile, olfactory, and gustatory hallucinations. Coming to delusions, delusions are fixed false beliefs that do not change even with evidence. Persecutory means they believe someone wants to harm them. Grandiose means exaggerated self-importance, like feeling like I'm the king, I'm the god, etc. Referential means believing TV or newspapers talk about them. Somatic means believing organs are damaged or rotten. Differentials of psychosis. Whenever you see psychosis, ask four questions. What is the timeline? Are mood symptoms present or not? Is there any history of substance abuse? Is there any medical illness? These four questions will guide your diagnosis in any case of psychosis differential. Schizophrenia requires a total duration of at least 6 months and with at least 1 month of active symptoms and functional decline in social or occupational life. It is a chronic disease. Symptoms includes positive, negative, and cognitive symptoms. Positive versus negative symptoms. Positive symptoms add abnormal experiences like hallucinations, delusions, and disorganized speech. Negative symptoms remove normal functions such as emotional expression, leading to flat affect, alogia, low speech, avolition, lack of motivation, and anhedonia, loss of emotional expression. So, the mnemonic for these negative symptoms is 5 A's. Flat affect, alogia, avolition, anhedonia, asociality, and affect. So, coming to schizophrenia spectrum disorders. Brief psychotic disorders last less than 1 month. Schizophrenia lasts for 6 to 1 months, 1 to 6 months. Schizophrenia lasts, I'm sorry, brief psychotic disorders last less than 1 month. Schizophrenia from disorders last for 1 to 6 months. Schizophrenia lasts for greater than 6 months, and schizoaffective includes both mood and psychotic symptoms. Both mood symptoms and psychotic symptoms are seen. Coming to schizoaffective disorder, the key concept is that psychosis must occur for at least 2 weeks without any mood symptoms. If psychosis happens only during mood episodes, it is mood disorder with psychotic features, not schizoaffective. So, the key feature of schizoaffective disorder is that psychosis occurs without mood symptoms for greater than 2 weeks. If mood symptoms are always present, then it indicates that it could be a mood disorder. Whereas if psychosis, if the mood disorder is independent of psychosis, then we can consider it as a schizoaffective disorder. Important risk factors of schizophrenia includes genetics, prenatal infections, use of cannabis, urban living, and increased dopamine activity. Medical causes of psychosis. We always need to rule out drugs like steroids, stimulants like cocaine, amphetamines, etc. We always need to rule out CNS infections, brain tumors, thyroid disease, systemic lupus erythematosus, Wilson's disease, and porphyria before labeling someone as a schizophrenic. So, let me repeat it once again. The medical causes of psychosis includes use of drugs, CNS infections, brain tumors, thyroid disease, SLE, Wilson's disease, and porphyria. We need to rule out these causes before labeling some patient or a person as a schizophrenic. Delirium is acute brain failure. It has sudden onset, fluctuates throughout the day, causes poor attention, disorganized thinking, and altered consciousness. Coming to differentiating between delirium, dementia, and psychosis, delirium is acute with impaired attention and fluctuating consciousness, whereas dementia is chronic, slow, and progressive with normal attention early in the early stages. Psychosis has normal attention and consciousness. The onset is variable. We have this single table is very high yield that it's worth repeating once again. Delirium is an acute onset disorder where attention is definitely impaired and consciousness fluctuates. In dementia, it is a chronic disorder. Attention in the early stages it is normal, whereas consciousness is normal. In psychosis, onset is variable. It could be acute or chronic in onset, but attention and consciousness are normal. Causes of delirium. There are there is a mnemonic like I watch death to remember the causes of delirium. So any of these could be causing delirium in a patient. These can include infections, withdrawal, metabolic problems, ec- trauma, CNS disease, hypoxia, deficiencies, endocrine problems, acute vascular problems like stroke, toxins, and heavy metals. So, the mnemonic is I watch death for the causes of delirium. These includes infection, withdrawal, acute metabolic conditions, trauma, CNS pathology, hypoxia, deficiencies, endocrine, acute vascular, toxins, and heavy metals. Management of delirium. We need to treat the underlying cause first. Then we need to give fluids and correct electrolyte balance, stop offending drugs, and start with low dose antipsychotic only if the patient is dangerously agitated. Antipsychotics are used in schizophrenia, acute psychosis, bipolar mania, and severe agitation in delirium. They mainly block dopamine D2 receptors. These antipsychotics mainly block dopamine D2 receptors. Types of antipsychotics. Typical or first generation antipsychotic drugs includes haloperidol and chlorpromazine, whereas atypical or second generation antipsychotics includes risperidone, olanzapine, quetiapine, and clozapine. Typical versus atypical. Typical antipsychotics strongly block dopamine and causes more extrapyramidal symptoms. What are these typical? These includes haloperidol and chlorpromazine, which cause strong dopamine blockage and more extrapyramidal symptoms. Whereas atypical antipsychotics like risperidone, olanzapine, quetiapine, and clozapine, they cause comparatively less extrapyramidal symptoms, but more metabolic side effects like weight gain and diabetes. Extrapyramidal symptoms. Acute dystonia causes painful muscle spasms. Akathisia is inner restlessness. Parkinsonism causes rigidity and tremor. Tardive dyskinesia causes involuntary lip smacking and tongue movements. These can be the observatory findings which can be seen in a patient who is said to have extrapyramidal symptoms. He or she might have stooped posture, masked facial expression, forward tilt of trunk, reduced arm swinging, rigidity, flexed elbows and wrists, trembling of extremities, slightly flexed hips and knees, shuffling, short stepped gait, acute dystonia muscle spasm, akathisia restlessness, Parkinsonism rigidity and tremor, tardive dyskinesia can present with lip smacking. Coming to the treatment of extrapyramidal symptoms. Dystonia and Parkinsonism are treated with benztropine or diphenhydramine. Akathisia is treated with propranolol, and tardive dyskinesia requires stopping the drug. Dystonia can be treated by giving benztropine and diphenhydramine. Parkinsonism can be treated by giving benztropine. Akathisia can be treated using propranolol. And if a patient presents with tardive dyskinesia, that is presentation with lip smacking or something like that, we need to stop the drug. Neuroleptic malignant syndrome. Neuroleptic malignant syndrome presents with high fever, rigidity, altered mental status, autonomic instability, and elevated creatine kinase. It is caused by antipsychotics and is a medical emergency. Neuroleptic malignant syndrome develops over days and has rigid muscles. Serotonin syndrome develops within hours and has hyperreflexia and clonus. This distinction between NMS and serotonin syndromes is frequently tested on USMLE. NMS onset is in days. Serotonin syndrome onset can occur within hours. In NMS, muscles are rigid, whereas in serotonin syndrome, there is hyperreflexia. The cause of NMS is usage of antipsychotic drugs. Cause of serotonin syndrome is serotonergic reuptake inhibitors and monoamine oxidase inhibitors. So this distinction between NMS and serotonin syndrome is highly tested on step 1. Clozapine is used in treatment-resistant schizophrenia. Major side effects includes agranulocytosis, seizures, myocarditis, and weight gain. CBC monitoring is mandatory in first patients who are kept on clozapine. So clozapine is used in treatment-resistant schizophrenia. Not all the cases of schizophrenia, but it is used in treatment-resistant schizophrenia. Side effects of clozapine includes agranulocytosis, seizures, myocarditis, weight gain. Someone who is on clozapine should be kept on CBC monitoring regularly. High yield side effects. So these are the must-know side effects that are very much tested on exams like USMLE. Haloperidol causes extrapyramidal symptoms. Haloperidol, as we have discussed, is a typical antipsychotic, whereas olanzapine causes weight gain, risperidone causes hyperprolactinemia, and clozapine causes agranulocytosis. Now we'll discuss four different cases that can be usually easily answered with pattern recognition identification. So, case one, 6 months of hallucinations in a 22-year-old. There is presence of social withdrawal and poor functioning. And from this, we can identify that things like 6 months, 6 months or more than 6 months, then it comes under a chronic psychiatric condition. There is social withdrawal, and there is also functional decline. All these things points out to a diagnosis of schizophrenia. And the most important point that leads us here is chronic duration. Case 2, 2 weeks of psychosis after stress with no past history and a stress trigger in a 30-year-old. This could indicate a brief psychotic disorder. Just 2 weeks of psychosis. There is no past history, but there is a presence of a stress trigger in an adult. Just 2 weeks. No past history, 2 weeks only. So this points out to a diagnosis of brief psychotic disorder. Case 3. An elderly patient with infection, urinary tract infection, who is confused at night and normal during day. There is a diurnal variation. The mental condition of the patient varies from uh, some part of the day to the other part of the day. So we just need to understand that he's an elderly patient with an infection. An infection could probably be most important cause of delirium, as we have discussed it from the mnemonic in the causes of delirium. So infection is the first one. So infection with a diurnal variation, confusion at night and normal in the mornings. So this points out to a diagnosis of delirium. Case 4. A patient is on haloperidol and he develops fever, rigidity, and confusion. Someone who is on haloperidol. Okay. This points out to a diagnosis of neuroleptic malignant syndrome, rigidity and confusion, and fever. All these things, along with a history of usage of haloperidol, points out to a diagnosis of neuroleptic malignant syndrome. So now we'll be discussing four USMLE style questions. First question, acute confusion with fluctuating attention. Acute confusion with fluctuating attention and infection. There is acute confusion and there is fluctuating attention and also infection. So this points out to a diagnosis of delirium. 8 months of hallucinations with flat effect. 8 months of hallucinations with a flat effect points out to a diagnosis of schizophrenia. Neck twisting after haloperidol points out to acute dystonia, which is an extrapyramidal symptom. So this acute dystonia should be treated with either benztropine or diphenhydramine. Yeah. So patient develops neck twisting. So neck twisting indicates acute dystonia, and after using haloperidol, this indicates an extrapyramidal symptom. Neck twisting, acute dystonia after usage of haloperidol points out to a diagnosis of acute dystonia, and it is treated with benztropine. Question 4. Fever and sore throat in a patient on clozapine. Fever and sore throat. So clozapine, most important side effect of some patient who is who have been using clozapine is agranulocytosis. That is why we asked someone who is on clozapine to be kept on regular complete blood count monitoring because agranulocytosis is a very high possibility in those patients who are kept on clozapine. Common exam traps includes we shouldn't confuse delirium with schizophrenia. Both are different. We always need to consider medications, always check the timeline, always think infection in elderly. Whenever there's a history given about an elderly patient, we always have to search for a history of any possible infection. And then we can, if there's something like infection, we can point out it to a diagnosis of delirium if the other symptoms match also. So we shouldn't get confused with NMS and serotonin syndrome. We have already discussed what are the differentiating factors between both of them. So this differentiation between NMS and serotonin syndrome is the biggest trap on step 1 exams. Chronic psychosis greater than 6 months indicates schizophrenia, acute confusion in any patient. If it's given, we should first think about delirium. Extrapyramidal symptoms are a highest possibility from typical or first generation antipsychotics. Fever and rigidity points out to neuroleptic malignant syndrome. Treatment-resistant cases of schizophrenia, those patients are kept on clozapine. Clozapine should not be easily and immediately be the first choice because it causes a high number of side effects, like agranulocytosis. Psychosis means loss of reality. Timeline is critical. We always need to rule out medical causes before coming and ending up at a psychiatric diagnosis. Antipsychotics cause extrapyramidal symptoms and neuroleptic malignant syndromes. Clozapine is a special drug and it's not the first line that should be preferred. In next video, we'll be discussing mood disorders, bipolar disorder, antidepressants, and suicide risk. This channel provides free structured USMLE education. Please subscribe for upcoming videos.